So thank you to all the panelists. I hope that this collection of presentations persuades you that healthcare is actually a wonderful domain of study for this new institute of IDSS, because it really covers all of the components that the institute is interested in studying. And I have a very strong desire to see IDSS work in this area, because I think it's critically important to apply the insights that come from the joint study of data systems and society to this very, very important problem. We're happy to take questions. If you would go to the microphone and please identify yourself.
Hi, I'm David Sontag. I'm a new faculty member here at MIT. So this question's for DJ Patil. So with regards to the Precision Medicine Initiative, one thing that's very exciting happening, that's been happening for, I think, over a decade at MIT, is something called the MIMIC database. It's a database of intensive care unit data derived from Beth Deaconess Medical Center, which is extremely easily accessible with a very simple data sharing agreement that takes basically one click and a little bit of information. The next day you have access to the data. And it's really, in the last few years, driven a huge amount of research in the computer science departments of the world toward trying to improve health information technology. Now, my concern is that the Precision Medicine Initiative is going to be creating this data that you're referring to, but which will not be as easily accessible as something like that. I think by making it, so my question to you is, how will you make it accessible to, let's say, computer science folks, both in academia and in Silicon Valley, who are not used to doing IRBs and who need access to longitudinal patient data?
Yeah, so the first part of that, the first framing of that, which is important to address, is actually the common rule. I can't comment much about that right now because we're in active rulemaking process, so it would not be appropriate for me to make anything other than saying the underlying aspects that you're referring to of common rule and the consents and all of that are deeply tied together with that. One of the things that the Precision Medicine Initiative builds on is actually multiple parts of different cornerstone projects. There's one example, which is the Million Veterans Program at the VA, which has now crossed 500,000 biosamples just down the street in the Maverick lab in Jamaica Plains. Then there's also the NIH cohort that is just starting to come together. Eric Dishman is going to be directing that program. A big component of that is very much focused on what is the spectrum of open data. And we have an executive order that says all data by default is open and machine readable. And what that looks like under implementation under precision medicine is that some aspect of that data will be fully open, and through additional controls, that data will be increasingly opened up. And that is very much in the evolution process, and I encourage people to stay very actively engaged as they start to build out those frameworks, and there's a number of workshops and traditional platforms where that is very actively being discussed right now. But our expectation is very strongly that the type of computer science style research that can happen because someone says, hey, if I have access to this and I can start looking at it, that is something that we want to massively foster while making sure that the necessary privacy protections are in place. If you're interested in those privacy security protections, if you do a search for White House and Precision Medicine Initiative data security frameworks or White House and trust and privacy frameworks, you'll get all of the guidance that we have outlined for those for those set of initiatives going forward.
Repeat one quick comment, and that is there are two ways Beth Israel Deaconess has thought about supporting your kinds of efforts. The first is, yes, our efforts. There we go. So the first is, as you say, we de-identify a large data set and then make that publicly available. So we do that with MIMIC, have it for several years. We also recently did it for this thing called the Argonaut Project, which is an open source application program interface development project. You'll find it at argonautproject.org. We took 3,000 comprehensive lifetime patient records and made them available to all partners in the Argonaut Project with one click for free. Now, it was really quite hard, as Pete knows, to do de-identification. So I can remove name, gender, date of birth, and all the rest of that stuff. But if a note says, this White House official was drunk again, that's not de-identified.
Nor in this administration.
Of course, of course. The other way is with this I2B2 approach. You find that at i2b2.org. You send the question to the data, as opposed to us sending the data to you. And for some use cases, not all, but for some use cases, that's sufficient. So in the case of my wife, if you said, how many Asian females with this particular diagnosis have had this particular med, you get an answer, 42. Again, not every use case, but for some.
So I just add that it is indeed a hard problem. If you read Cynthia Dwork's work and the people who do work like hers, you quickly discover that most intuitively attractive de-identification schemes, at least theoretically, leak data. And so the question is, what sort of risk are you willing to take, and what sort of adversary are you expecting to encounter in doing this?
Hi, I'm Jeff Marcus. I'm a data scientist at Kayak, and I guess my question for DJ is, what determines what you work on? Is it coming from you? Is it coming from the administration? And also, how big a staff do you have?
So the framework of how we think about this problem, there's a Washington Post article that just actually walked through this that got published yesterday. But the high line is, it's a really tough problem. I mean, when you get to any of these federal levels, like at FDA or anything, you kind of say, you walk in and you're like, well, what's the problem of the day? Everyone's like, every problem is of today. So our framework is very simple. It has to impact at least $1 trillion of spend or of savings, impacts 1/2 of the United States population, or helps a population that has no active recourse. So healthcare, criminal justice, mental health issues, do a lot on LGBT, do a lot with disabilities and other groups as well. Those projects are weighed up against the presidential priorities, and then the president actually gives us our direction of how do we apply our things. On my direct team, as an example, there's about 6 people on our staff, but there's an incredible cadre of people in the agencies that we work across depending on which level. The president has a science advisory board called PCAST. And then there is what I have is called the data cabinet, which are the leads of the different agencies that have data leaders. There are about 25 of those. And then there's also an intelligence component. And those kind of groups that then come together, we meet at least once a month to review progress, as also to figure out how to do better cross-sharing across of these. So for example, in NIH, there's multiple data leaders, obviously, for an organization like that, as well as broad HHS, but including Rob Califf's organization at FDA, but also Department of Transportation, Dan Morgan, who's the chief data officer there, and some of you may have seen that we released a large data set 3 months early around the fact that traffic fatalities are up by 7.2% from the last year, and we're asking the public to say, hey, this is a pristine data set. Everybody that's an economist or somebody else should take a look at this data set, combine it with other data sets to help us understand what is actually going on in those areas.
Thank you very much.
Hi, I'm Vijay Chandra. I run a precision medicine company in India. So my question is a little bit about how are we thinking about this globally? Because, people travel, so they could be US citizens overseas when access is required to their health data, and vice versa. I mean, I think we talked about ethnicities here who are from all over the world, and how that data should be integrated. So is there actually a sort of an international perspective on this that the White House has?
There's no international framework at this time. There is for cancer that was just announced last week, actually early part of this week at the UN General Assembly meeting, and as well as the agreements and future proposed agreements with Australia for that type of data sharing. But I think the place where you're going to see much more of this, to be very honest, is going to be the frameworks are there for the protection at the broad federal level, but I'd actually be more interested. I think the real way we're going to see this is happening at the direct concrete research level, like all these things. That's where the rubber hits the road. So,
yeah. So there are two things happening right now. First, in the United States, we're moving to a national IRB, which is actually very important. And at MIT, we've been part of a seed agreement where IRB approval, that is approval to access data and patients and actually use and engage in research, approval at one of our 32 members of our network can be ceded to any of the others. And soon across the United States that will happen, and we're envisioning implementing this on an international scale. The other thing to recognize in research and technology development is much we are one world, we're not. And human factors and behavioral sciences have been poorly appreciated in the impact of technology, as well as the fact that, as John mentioned, the fact that his wife is of Asian descent plays a role. So the implementation, for example, in the United States of certain technologies in the African American community is very different than it is in other communities. The technologies that have been evaluated principally in men don't apply to women. So while there are therefore these two competing forces, we are internationalizing and globalizing our research, but we may be doing that at the risk of losing track of regional, cultural, societal, and ethnic and racial responses to disease and therapy.
And one quick comment on the standards. Whenever we choose interoperability standards as a country, we actually look to international standards first. So, for example, the use of SNOMED CT, international standard, and that's really used for all of our problem lists and using for data classification, LOINC codes, and others. So, to the extent that there will be policy that enables the transition of data from place to place, the data standards should be internationally compliant.
Thank you.
Sort of a related note of caution, we just had a paper in New England Journal a couple of weeks ago where one of our students did a study on hypertrophic cardiomyopathy, which it turns out that the genetics in a mostly European population in which this studies were initially done implicated a gene as being causative of this disorder. That gene turns out to be fairly prominently present in African and African American populations and appears not to be associated with this disorder. And so a lot of American blacks were told that because they have this gene, they're at serious risk for a debilitating disease, which was not true. And so this is an example of the real critical importance of getting international and really worldwide collection of data so that we're not misled by these statistical relationships from limited subpopulations. Yes, sir.
So a lot of discussions about personalization of medical care and targeted treatment and precision treatment. I wonder if you have any thoughts on whether there are any downsides to personalization of medical care. And specifically, I'm thinking of sort of replicatability of procedures, and when you have a uniform sort of treatment plan, that it's easier for doctors to perform that, whether losing that is a problem within the system that is outweighed by the benefit of the personalized care.
Wow, what a tough question. So let me take a quick stab at it. So I was the second human sequenced in the Personal Genome Project. So if you go to personalgenomes.org, patient number 2, you can look at my genome, my medical history, in fact, my weight this morning. I have no privacy of any kind. My genome, you'll see, suggests that I'll die of prostate cancer. Now, the New England Journal says, quit ordering PSA tests because they haven't shown over 10 years to reduce morbidity or mortality. But wait, I'm going to die of prostate cancer. On the other hand, I'm a vegan. So I have no exogenous source of cholesterol, and by the way, my cholesterol is 72. I have no family history of heart disease or stroke. So the New England Journal says you better order cholesterol tests on patients every year. Why? So my doctor has said, let me take your genome, your exposome, your phenotype, put it all together. And you know, for me, I get PSA tests every year, but I get no cholesterol measurement of any kind. So I don't know. Seems like a better use of resources than following a generalized guideline.
So if I would like to amplify on that. The problem is not with precision medicine. The problem is with an understanding and interpretation of what that means. So we've misinterpreted precision medicine in the same way that we've misinterpreted, for example, big data. Precision medicine at its heart means you listen to your patient. And unfortunately, what you heard from John with regard to keystrokes earlier is that the amount of time we have to spend with our patients is being sucked away from our FaceTime with the computer. So precision medicine is the ability to understand that we now have an overabundance of alternatives in terms of therapies and diagnostic modalities, and they have to be made contextual. And that context needs to include the environment in which they act and work and live, as well as the people that are interacting with them, the physicians and clinicians and everyone else. So there's nothing wrong with physician medicine except when it is abused in a blind way to apply things that are actually imprecise and inappropriately applied.
So on that note of wisdom, I think I will close the session and encourage you all to go hit the coffee. Thank you.